Good evening, everyone. Today we'll be discussing the final proof topics on the neurology, and this is going to be the final session of the medicine paper one. Uh, and we have discussed other system previously. You can check out the playlist, and now we're discussing the neurology part. So let's discuss it without any further delay. So the first question I saw about the CS from the neurology was the cerebrospinal fluid examination. So, what is the importance of cerebrospinal fluid examination? The question was like this. So, importance or indication, it's the same. So, it is asking you the indications of the cerebrospinal fluid examination. So, as we know, we do the cerebrospinal fluid examination in case of the meningitis. So we can also differentiate between the bacterial, viral, and tubercular on the basis of the CSF examination. Another one is if we found the bloody CSF, there is a blood present, so subarachnoid hemorrhage, we can diagnose the subarachnoid hemorrhage. Another one is multiple sclerosis. There are oligoclonal immunoglobulin band present in the CSF in multiple sclerosis. Another one is GBS, Guillain-Barré syndrome, in which we find the albuminocytological dissociation. That means the blood cells of the cerebrospinal fluid are the protein part is increased, but the cell count is the normal. So there is an albuminocytological dissociation. Another one is we can also like the indication of the CSF examination, like the fluid tapping in the treatment of idiopathic intracranial hypertension. So also called the pseudotumor cerebri. So these are the indications of the CSF examination. So now let's move on to the headache. So the headache, what are the types of headache? So this is important questions. So what are the types of headache? So in the types, there is primary headache and the secondary headache. So in the primary headache, the most common type of the headache is a tension type headache. Okay, tension headache. Tension headache is the most common one. Then other one are the migraine headache, and another one is a cluster headache. Another one, special one is the trigeminal neuralgia, in which there is a pain in the trigeminal region, trigeminal neuralgia. So these are the primary headache, and if the examiner asks you what is the most common cause of the headache, you should answer it is tension headache. So this is most common headache. And let's move on to the secondary headache. So secondary cause of the headache is usually due to the dangerous causes. So if there is any intracranial bleeding, or if there is any cause that increase the intracranial pressure, or if there is any inflammatory process going on, infectious process going on, and medication overdose such as nifedipine, like calcium channel blocker and glyceryl trinitrate. So these are the causes of the secondary. So secondary means when there is intracranial bleeding. One is intracranial bleeding, another one is increased intracranial pressure, right? Then infectious cause like meningitis, this, and inflammatory. So there is a specific one important cause that is called the giant cell neuritis, or temporal arteritis. So this is special when palpating on the temporal side of the region, there is a headache. So this is important because this is a vasculitis, that is giant cell. That's why it is called giant cell arteritis. And another one is a medication induced. We have glyceryl trinitrate and the calcium channel blocker. So these are the causes of headache. So now, how can you differentiate between the tension, migraine, cluster, trigeminal neuralgia? So there are important clinical clues that can like differentiate between all these types of the headache. So the tension type headache is the headache that occurs bilaterally, okay, bilaterally in band-like distribution. So band-like distribution. What is band like? So when you put a band on the forehead like that type, so this is the characteristic of this headache. So this headache usually lasts more than 30 minutes, usually for 4 to 6 hours. uh, then comes to the migraine. Migraine, there is a unilateral. It is unilateral headache. Okay, unilateral headache. It is usually the most like the dictating feature is that it is associated with the photophobia and phonophobia. Very sensitive patient is very sensitive to the light and noise. So photophobia, phonophobia is the important characteristic. Photophobia, phonophobia. Then another one is aura. The patient, usually the patient have aura before the attack, and another one is a cluster headache, which is exclusively occurs in the male, and this is a unilateral periorbital region headache, periorbital region headache. So this headache usually lasts for 15 minutes to 3 hours. So this headache is very common in the male, and usually it is associated with what? It is associated with the rhinorrhea, lacrimation. So the patient on the same side will have, there is a rhinorrhea and lacrimation. So another one is a trigeminal neuralgia. So in trigeminal neuralgia, there is a shooting pain along the distribution of the uh, nerve, of this nerve, trigeminal nerve, and it is usually triggered by the touching, chewing, or touching, chewing. So one important treatment, like the important drug we use for the treatment of the trigeminal neuralgia is drug of choice is carbamazepine. Carbamazepine. So I'm telling you the important points that can be asked. So in case of the secondary headache, secondary cause of the headache, so as we've said, giant cell arteritis, as I've said, there is a on palpation on the temporal region, there is a pain, and medication induced, there is a history of the medication use, infectious causes, there is a fever, or resistant there might be, like if there is a tremor or something causing the headache, so there will be a focal neurologic deficit. You look for the focal neurologic deficit. Okay, these are the causes and how you can differentiate between the different types of the headache. So now let's come to the there is another one important topic. So unconsciousness. So there was a question: how can you evaluate? How do you evaluate a patient, treat a patient with the unconscious? If the patient comes with unconsciousness, so if the patient comes unconscious, so you have like a very wide range of the differential diagnosis in your mind. So most commonest causes are the metabolic cause, and another one is a vascular cause, infectious cause, and if there is any trauma, right? So these are the main four headings we can differentiate. So in case of the metabolic, so their metabolic, most commonly the most patiently the diabetic coma, when there is a hypoglycemia, episodes of the hypoglycemia, or if there is a very high blood glucose level in case of the diabetic ketoacidosis or hyperosmolar hyperglycemic state, right? So another one metabolic cause is another one is hyponatremia, electrolyte cause hyponatremia. Okay, then another one is the encephalopathy, like encephalopathy may be due to uremia, hypertension, or hepatic encephalopathy. Okay. Then another one is the vascular. When there is any like a hemorrhages, vascular cause. In vascular cause, when there is any cerebral hemorrhages, so that will present as unconsciousness. Another one is infection. Infection in case of the malaria endemic zone, we have cerebral malaria, and infection. Other infection are the meningitis, brain infection, meningitis, encephalitis. So encephalitis. So this can present with unconsciousness. Another one is a history of the trauma. Okay. So a trauma, and there is hematoma, subdural, epidural hematoma, then it can present as a unconsciousness. So now these are the main headings of the causes of the unconsciousness. So how you going to evaluate a patient with unconsciousness? So if the patient comes, so first thing is initial assessment would be, first initial assessment would be GCS. You'll measure the Glasgow Coma scale, right? Then you like assess the airway, breathing, and circulation part. Then you assess if there is any pupil dilatation, like in case of the traumatic trauma, there is a traumatic mydriasis, right? And if there is an infectious cause, there will be a temperature. Okay, so now the immediate management, immediately you have to do immediate management is like the airway. In case of the airway, so if the patient has a secretion in the oropharynx, the oropharyngeal suction is given, so to ensure the airway patency. Okay, in case of the airway. In breathing, breathing in breathing, if the patient is like the saturation is low, we give the oxygen supplementation. And if the patient is not able to breathe, then the intubation is necessary. So breathing. And in case of the circulation, we establish the IV cannula, and the fluid is given, right? So we have to ensure the IV cannula to administer the drug as well as the fluid. So this is the immediate management, ABC management. Then comes the general management. In case of the general management, for the care of the skin, like the patient, the posture should be changed 2 hourly, and the feeding should be given NG by the nasogastric, via the nasogastric route, right? And for the care of the eyes, you have to give the antibiotic, the eye drop, right? And for the bladder care, you have to catheterize the patient as well as to maintain the urinary output, as the patient may be in the shock, right? So these are the general management we give. Okay, and then we do the investigation. So invest for the part of the investigation. So investigation, look at here. So for the diabetic coma, you have, if you do the blood glucose level, so you'll know that it is diabetic coma or not. So if you do the serum electrolytes, then you'll know the hyponatremia. And if you do the serum urea level, right, blood urea nitrogen level, and if you measure the hypertension, you're gonna know that it is a case of the hypertensive encephalopathy. So for the hepatic encephalopathy, so there is a history of the like the CLD, right? Chronic liver disease history that way. And for the vascular cause, you do the CT scan of the brain. Okay, CT scan of the brain. And for the infectious causes, there you can do the CSF study, right? For the malaria test, you can do the ICT for malaria. So for the trauma too, so you can do the CT scan. So these are the investigation to diagnose the cause. And we do the general investigation, like general investigation. So general investigation we do for all patients, like CBC, serum creatinine, chest X, CXR, ECG. These are the general investigation we give for the patient, and the specific are the electrolyte, blood glucose level, then CT scan. These are the specific investigation we do. So, and after doing the investigation and finding out the cause, then we do the treatment of the specific cause. So if it's due to the decrease in blood sugar, so we give the blood sugar containing fluids. And if there is hyponatremia, we maintain like the increase the sodium level by giving the normal saline, right? So this is how we approach the patient with unconsciousness. So this is all about the unconsciousness. Then let's move on to the Bell's palsy part. So as you can see in this gentleman has the Bell's palsy. So how can you what is Bell's palsy? First, let me tell you. So Bell's palsy is the unilateral lower motor neuron type of the facial nerve injury, facial nerve palsy. Okay, unilateral lower motor neuron type of facial nerve palsy. Okay, facial nerve palsy. So, uh, So clinically, you see the patient will have, this is affected side, okay? The left hand side, the right hand side of this patient is affected. So there is loss of wrinkling, and the in this figure it is not so appreciated, but whenever the patient closes eye, there is incomplete closing of the eyes, okay? So patients would not be not able to close the eye totally. And another one is Bell's phenomenon. There is upward and outward movement of eyeball when closing, while closing. So this is also you can appreciate if the patient while closing the eye, then there is will be loss of the nasolabial fluid, and the patient mouth is deviated to the opposite side. You can see the patient mouth is deviated to the opposite side. So this is Bell's palsy. So there was a short note on Bell's palsy. So you just write the definition and the clinical features you see. Then comes the cause. So most common cause of the Bell's palsy is idiopathic. Remember, cause of the Bell's palsy is idiopathic. Okay. Then comes the treatment. So for the treatment part, the physiotherapy, and giving the artificial tear, and antibiotic drop, and the steroid. These are the treatment. So physiotherapy is an important one. So 80% of the patient within like the 3 months will have complete resolution. So physiotherapy, prednisolone, giving the prednisolone and the artificial tear and antibiotic drop is the treatment for the Bell's palsy. So now let's move on to the paraplegia. Okay. So there was a question about what are the causes and how do we investigate a case of the paraplegia. So for the paraplegia, so there are two types of paraplegia. One is spastic type, one is flaccid type of paraplegia. Okay? One is spastic, one is flaccid. So spastic is due to the upper motor neuron type of the lesion. Okay, spastic is due to the spastic is due to the upper motor neuron type lesion, and flaccid is due to the lower motor neuron. So in case of the upper motor neuron type of the lesion, so if there is a compression, spinal cord compression in the spastic, let me tell you the causes. Compression, 3T. Okay, you remember with the 3T, one is a trauma, one is tumor, any tumor compressing it, and another one is tuberculosis. So this is the compressive cause of the spastic paralysis. Okay, and there are non-compressive causes like transverse myelitis, acute transverse myelitis, multiple sclerosis, and the amyotrophic lateral sclerosis. These are the non-compressive cause. And here come to the flaccid type of the paraplegia. So flaccid type of the paraplegia is due to the lower motor neuron type of the lesion. So lower motor neuron. So if there is any involvement in the peripheral nerve, like the in case of the Guillain-Barré syndrome, and peripheral neuropathy due to any cause, right? And another one important one is hypokalemic periodic paralysis. So hypokalemic periodic paralysis. And another one is myasthenia gravis, Lambert-Eaton syndrome, can also present as a flaccid type of paralysis, as it is a lower motor neuron type, right? So how do you investigate this? So let's see here, investigate this case. To investigate trauma, tumor, tuberculosis, we can do CT scan and see this, right? If we do the CT scan or MRI of the spine, we can clearly demonstrate the tumor and trauma, right? And the tuberculosis, we can also do the see through the like the CT scan, that like bony involvement of the TB. But for the primary focus, we can also do the chest X-ray. And for the non-compressive part, the amyotrophic lateral sclerosis. So in case of these multiple sclerosis, we can do the CFS study to find out the cause. And for the flaccid type of the flaccid type, so we have to do the serum electrolytes to find out this is a case of the hypothalamic periodic paralysis, and we have to do the neuronal examination. So this is how we can specifically like think about the investigate about the cause CSF study for the GVS. These are the specific investigation, and other general investigation we give. Other will be a general investigation to find out the causes of the peripheral neuropathy. So other will be the general investigation. Now let's move on to the what are the causes of hemiplegia. So hemiplegia. So hemiplegia. So hemiplegia means like there is a paralysis, like the patient cannot move one side of the body. The paresis means weakness, just the weakness. The plasia means the complete paralysis, complete loss of the power. Okay. So what are the causes of hemiplegia? So causes, the important causes are the stroke, the most common one, stroke or transient ischemic attack. If it is resolved within the 24 hours, it is transient ischemic attack. So if there is a trauma to the brain that is causing the subdural epidural hematoma, that can also present as the hemiplegia. Another one is the tumors, any tumors presenting. Another one is functional. Functional means the patient is mimicking functional hysteria. So these are the commonest cause of the hemiplegia, and we can investigate this by doing the CT scan. By doing the CT scan, we can clearly demonstrate all the causes, and we can find out all the causes. And other investigation we do is to look for the risk factors. Like what are the risk factors? Another question was, what are the risk factors you look in patient with the hemiplegia. So we'll look if there is any family history. We'll look if there is any cause of the diabetes mellitus or hypertension or any cardiac disease that will indicate it has caused the stroke or something else and present as the hemiplegia. So now let's move on to the epilepsy part. So epilepsy, the question asked is about what describe the grand mal epilepsy. So grand mal epilepsy, we have four phases. First phase is aura. So we have phases of grand mal epilepsy. First phase is aura. Aura means like the patient, it depends on what lobe it involves. It typically involves temporal lobe, and there is aura about the auditory and visual hallucination. And the patient, and there is one phenomenon called the deja vu phenomenon, that is increased familiarness to the unfamiliar object. কোনো unfamiliar object চিনা মতো লাগলে deja vu, this is called the deja vu phenomenon. And another one is automatism, like lip smacking, chewing. These are the aura. These features we can see in the aura phase. Another phase is a tonic phase. In tonic phase, the body becomes rigid and the patient falls, and we can appreciate like if there is a respiratory arrest, we can see the cyanosis building up there. So this is in a tonic phase. Another one is a clonic phase. So in this phase, the patient is relaxed. Like after some tonic phase, then comes the clonic phase, right? In clonic phase, the patient is relaxed and there is urinary incontinence. You can see that there will be like the tongue biting present. Okay, so this is in a clonic phase, and comes the post-ictal phase. In post-ictal phase, the patient is delirious, the patient is amnestic, the patient can't remember anything, and the patient suffers from the headache. So these are the features. So this is how the grand mal epilepsy, the phases is appreciated. We can appreciate this phases of the grand mal epilepsy. Now, the one important one is the what are the principle of management of primary epilepsy. So they are asking about the principle of management. So the principal management is like we start a first line drug. So first thing is we start with first line drug with low dose. So start a first line drug with a low dose, then gradually increase the dose to obtain like the control of the seizure, then gradually increase the dose. Okay, so gradually increase the dose. And next thing, if the first line drug fails, we start a second line drug. We start second line drug. We start second line drug by, and also simultaneously we gradually tapers the first line drug. So we gradually tapering of the first line drug. Okay, first line drug we gradually taper. Then if this second line drug also fails, we use the combination of the first and second line drugs. Okay, and if the combination also fails, we start alternate, replace the what you have started the second line drug, we replace the second line drug. So alternate second line drug, we use the alternate second line drug. And if the patient seizure is not controlling, so you have to think about the compliance. Does the patient checking the taking drug properly in time, or they are just like they are avoiding the drug? You have to see this. And then another one is reconsidering your diagnosis. Your diagnosis might be wrong, so reconsidering your diagnosis. So this is the principle of management of the primary epilepsy. Okay, so another one, like the status epilepticus. So when the seizure occurs without any, the patient without regaining consciousness, the seizures reoccurring. So that is status epilepticus, right? So the status epilepticus, there is a management plan. So for the management of the status epilepticus, uh, firstly, we use what? We use benzodiazepines. We use diazepam or lorazepam. So first line drug is diazepam. So 10 milligram IV diazepam is given usually. So if the patient like the it did not control, we can use phenytoin. We then move on to the phenytoin or phosphenitoin. We can move to the phenytoin or phosphenitoin. If the seizure still is occurring, then we can use phenobarbital, or we can use what? We can directly move on to like the we can anesthetize patient with the propofol, uh, or midazolam. Sorry. So first one was benzodiazepines. Then we move on to the phenytoin or phosphenitoin. Then we move on to the phenobarbital, if not controlled, phenobarbital. Then if not controlled, we move on to with the anesthetics like propofol, midazolam, and this is done in the ICU. Okay, then ICU management is required. This is the like how you go. Like if benzodiazepines is not enough, then phenytoin, phosphenitoin, then phenobarbital, then propofol and midazolam. So this is about the status epilepticus. So another one is one written question was, what are the causes of tremor? So what are the causes of tremor? So tremor, we have different types of the tremor. One is a resting tremor, three types: resting tremor, intention tremor, and another one is uh, postural tremor. Resting tremor, intention tremor, another one is postural tremor. So resting tremor, the patient tremor occurs at first, that is seen in the Parkinson's disease. Another one is intentional tremor seen in the cerebral lesions, any cerebral conditions. Another one is postural tremor. So in postural tremor, we have different types of postural tremor. So one is benign essential tremor. In postural tremor, one is benign essential tremor. So benign essential tremor, there is one important association. There is the titubation. It is called titubation. There is a head nodding present, and we treat it with the beta blocker. And the patient will say that, like, after having some drinks of alcohol, my shaky hands will get like the better, you know. There are many like the patients, they will tell you these features. So that is the benign essential tremor. Another one is a physiological tremor. Physiological tremor, we can appreciate this on anxiety, thyrotoxicosis patient, right? Another one is drug-induced tremor. Drug-induced like salbutamol, theophylline, tacrolimus, this drug-induced the tremor. Another one is a flapping tremor. That is called the flapping tremor. We can say in organ failure, like liver failure, renal failure, respiratory failure. This we can say in the organ failure. So these are the causes of tremor. Now let's move on to the chorea and gait. So what is chorea? So chorea is the involuntary. So it is an involuntary, purposeless. So remember, so chorea is the uh, chorea is involuntary, purposeless, jerky movements of the limbs. Okay, jerky movements. We This is like the jerky, like the chorea means the Greek word for the dance. So there will be jerky movements of the limbs. So this is the chorea. So chorea, we the causes, like if it comes in a short note, or what are the causes of chorea. So you can write the common causes of chorea, like the sudden chorea in the rheumatic fever. Then in case of the Huntington's disease, Wilson's disease, and like some drugs can also induce the chorea, like the levodopa, oral contraceptives. So you can write this. So chorea occurs due to the lesions in the basal ganglia. Okay, remember, any lesions on the basal ganglia that will cause the chorea. And another one is a gait. So what the question was, what are the abnormal gaits? This Tell me the five important abnormal gaits. Abnormal gaits. So it was a question, written question. So one is antalgic gait. Antalgic gait means if there is a pain, the patient will be a limping, limping, pain, limping. So there is antalgic gait. Another one is a hemiplegic gait. So hemiplegic gait. Hemiplegic gait, we see in a patient with the upper motor neuron lesion, so we can appreciate the hemiplegic gait. Another one is the ataxic gait. Ataxic gait, we see in the cerebral dysfunction, we see ataxic gait. Another one is the festinant gait. So this is important gait, festinant gait. So it is the characteristic of the Parkinson's disease. Okay, Parkinson's disease, festinant gait. Another one is a waddling gait. Waddling gait. We see in the proximal myopathy. Okay, proximal myopathy. So these are the abnormal gaits with its causes. Okay. So now let's move on to the important topic, the stroke. So what is stroke? So in definition, you can't miss the important terms used there. So what is stroke? In definition, stroke is the focal neurologic deficit. Okay, so definition, you have to include focal neurological deficit. So stroke is focal neurologic deficit due to non-traumatic vascular cause. You have to remember, non-traumatic vascular cause. Non-traumatic vascular cause, either hemorrhagic or ischemic. Okay, either hemorrhagic or ischemic, lasting for more than 24 hours. So these are the important terms you should not miss on the definition of the stroke. So stroke is a focal neurologic deficit due to non-traumatic vascular cause, either ischemic or hemorrhagic, lasting for more than 24 hours. So we are saying lasting for more than 24 hours because if the stroke were resolved within 24 hours, if it resolved within 24 hours, then we call it transient ischemic attack. So if the stroke resolved within the 24 hours, we call it transient ischemic attack. So transient ischemic attack, the treatment would be like to prevent the happening of the stroke. So we give the aspirin, low dose aspirin to prevent the ischemic attack. So then come to the risk factors. So what are the risk factors of this stroke? So risk factors are, one are modifiable risk factor, another one is non-modifiable risk factors. So modifiable risk factors are important to us because we can modify it and to prevent the happening of this stroke. So for the modifiable, hypertension, diabetes mellitus, smoking, hyperlipidemia, and heart diseases. These are the five important risk factor of the stroke. What are those? Diabetes, hypertension, smoking, hyperlipidemia, and the cardiac diseases. Okay. And in the non-modifiable risk factor, we have age, gender, male. We commonly say in the male, and we have the like the hereditary cause, any hereditary factors, right? And race, the Asian population have highest incidence. So these are the non-modifiable risk factor which we cannot influence. We have to influence on the modifiable risk factor. Now let's come into the. I have discussed about the transient ischemic attack. Now let's come into the like the how the patient presentation in the written question and the how you're going to evaluate those cases. So one question was like the investigation and treatment. So patient came with the hemiparesis, right-sided hemiparesis. How do you like the patient develops sudden weakness of the right side of the body with motor aphasia? What may be the cause? What may be the possible side of the lesion? So these are the questions. So the patient will have the weakness, like in your written question, the patient will present with a weakness, or there is any like the difficulty in speech, or there is the seizure in case of the hemorrhagic stroke. The seizure is common. And so they will usually say about the hemiparesis and ask about the risk factor and others. But the evaluation of the uh, stroke is important. So whenever you think the patient came with a stroke, any facial deviation, right? Then arm problem, like the hemiparesis, hemiplegia, we have to think it as a stroke. And the immediate, like the evaluation should in a stroke is CT scan. So we do CT scan immediately. Okay, after arriving the patient at the hospital, we do CT scan. Generally, we cannot see the ischemic stroke within the like the 6 to 7 hours, but we do CT scan immediately to exclude, like to differentiate. Either it is like to exclude hemorrhagic stroke. So hemorrhagic stroke is seen immediately in the CT scan. So to exclude the hemorrhagic stroke and start treatment for the ischemic stroke, we do the CT scan. So CT scan, we can differentiate between the hemorrhage, and you can exclude hemorrhage and ischemic. So then now we start the treatment. Okay. So now we start for the ischemic stroke. The treatment is antiplatelet drug. That is aspirin, clopidogrel. These are the antiplatelet drug treatment for the ischemic stroke. So antiplatelet drug is the treatment. Then comes into the general management, like control of the general management, like the skin care, like the you have to change the bed posture. Then we have to like the control temperature control. We have to blood glucose control if the patient is diabetic, and we have to control the blood pressure. But we do not decrease the blood pressure abruptly. We slowly decrease the blood pressure. We have to lower the cholesterol by giving the anti-statins drug. So this is how we do. Like first CT scan, then we differentiate if it is ischemic or hemorrhagic. If the hemorrhagic, then the neurosurgery will manage it. And if it is ischemic, like the neuromedicine will manage it, and with the antiplatelet drug and the general treatment. And if it is hemorrhagic, so there was a question asked about the subarachnoid hemorrhage. So subarachnoid hemorrhage is usually due to the rupture of the berry aneurysm, and there is a rupture of the any AV malformation, arteriovenous malformation. So that is the cause of the subarachnoid hemorrhage. So subarachnoid hemorrhage, usually the patient with complaints about the severe headache, that is also called the thunderclap headache. Severe headache, that the patient will complain like the worst headache of my life. So these patients will go into the neurosurgery department, and the treatment will be the general management would be the same. The airway, breathing, circulation management, then other general management would be the same. But the specific treatment here would be if there is any vascular aneurysm, then we have to go for the surgery like neurosurgical clipping, and to prevent the vasospasm, that like the reflex vasospasm due to the blood, like the extravasation of the blood, we give the calcium channel blocker like the nimodipine. So this is the treatment of the stroke. So now move on to the Parkinson's disease. So what is the like the hallmark of Parkinsonism is like there is a decrease in the dopamine. So decrease in dopamine, right? Dopamine. So hallmark of this is decrease in dopamine. So uh, the patient, how the patient gonna present? So there was asked like a short note about the Parkinsonism. So how the patient presentation? Patient presentation. Firstly, patient presentation is, you can remember by the BRIT mnemonic. So bradykinesia. One is bradykinesia. Another one is a resting tremor. Resting tremor. Another one is I the inability to maintain posture. Okay. T the sorry, resting tremor. R the rigidity. Sorry. So R the rigidity, and another one is T the tremor, resting tremor power. So in bradykinesia means the less movement, right? Minus slowness, any slowness of the gait is the bradykinesia. In the rigidity part, we have two rigidity. Okay, one is cogwheel rigidity, another was is a lead pipe rigidity. So cogwheel rigidity means like the patient have like it is appreciated in the upper limb, and due to the underlying resting tremor, the patient when you move the hand, the patient will have the like the chain. You see the cycle chain. There is a like there is stopping and then a movement, stopping and movement type rigidity, that is cogwheel rigidity. Okay, so another lead pipe rigidity is one is cogwheel, and another lead pipe rigidity. Lead pipe rigidity is seen in the lower limb. So lower limb, there will be a continuous, constant resistance. So that is lead pipe rigidity. This is the presentation. And now, one another important thing was the what describe the gait of Parkinsonism. So how the patient gait of the Parkinsonism. So there will be a slowness in sitting up. First is when the patient is sitting and standing up, there will be a slowness on slowness, and there is a slowness in initiation of walking. For the initiation, the patient will be slowly initiate, and there will be a short and shuffling. The patient will have the short and shuffling gait, and there will be stooped posture. The posture will be stooped, and there will be a loss of hand swinging movements will be lost. And if you ask the patient to stop walking, there will be a slowness in stopping the walking, and there will be a slowness in the like the turning, the quick return will be lost. So this is the gait of the Parkinsonism. The gait is called the festinant gait. Festinant gait, that can festinant gait. This can come as the MCQ question. What is the gait of Parkinsonism? So this is about the gait of the Parkinson. So we make this diagnosis clinically, but we have to exclude other causes. To exclude like the other causes, we do the CT MRI of the brain, or to exclude other. And for the treatment part of the Parkinsonism, so the treatment of the Parkinsonism is medical treatment. We have medical treatment, and we have surgical treatment like deep brain stimulation surgery. Okay, the deep brain stimulation, we stimulate the brain, and so the patient will the tremor will be like there will be control in the tremor, and the movement will be controlled. For the medical treatment, we give the replacement like the levodopa plus carbidopa combination. Levodopa plus carbidopa combination. Carbidopa carbidopa to prevent the breakdown of the dopamine, levodopa, outside like peripherally. And we use the dopamine agonist like the bromocriptine, carbapenem, ropinirole, pramipexole, right? And to control the tremor and rigidity, we give the anticholinergic agents, anticholinergic procyclidine, like procyclidine, we use anticholinergic. And another drug are the monoamine oxidase inhibitor, and the we can use catechol-methyl comp inhibitor, that is entacapone, tolcapone, right? Then another antiviral drug we can use in the treatment of the Parkinsonism is amantadine. Okay, and the surgical treatment is deep brain stimulation test. So this is stimulating the brain. Okay, this is all about the Parkinsonism. Now let's move on to the peripheral neuropathy. So from the peripheral neuropathy part, the question asks what are the causes of peripheral neuropathy? So what are the causes of peripheral neuropathy? So causes of peripheral neuropathy, we can remember by the mnemonic, DAM it, DAM, DAM it, VIC, VIC. Okay. So first D, always, if any patient came with the peripheral neuropathy, you have to exclude the diabetes mellitus first. Okay, so diabetes is the first differential diagnosis in mind if the patient presents with the peripheral neuropathy. A দিয়ে হচ্ছে কি, A দিয়ে হচ্ছে কি alcohol, M দিয়ে metabolic cause like uremia, right? And another one is inflammatory cause. I দিয়ে হচ্ছে কি inflammatory cause. We have like the Guillain-Barré syndrome, we have vasculitis like polyarteritis nodosa. So these are the inflammatory cause. Arecta as infective cause like leprosy, you know. Then as T দিয়ে হচ্ছে কি toxin মধ্যে drugs such as isoniazid. So that is very neurotoxic. So we give with the vitamin B6 combination, pyridoxine combination. So toxin the arsenic toxin, lead acid. So these are the toxic causes of the peripheral neuropathy. Then V দিয়ে হচ্ছে কি তোমার vitamin deficiency like vitamin B1, B6, B12 deficiency, this will cause VI. তারপরে C দিয়ে হচ্ছে any cancer that can cause the paraneoplastic syndrome. So peripheral neuropathy, the patients, if the motor system is involved, then it will present as a lower motor neuron type of the lesion. If the sensory part is involved, then the patient will like complain about the pain, temperature, you know, there is a joint sensation loss, and there will be a tingling, numbness. This will be a sensory problem. And there can also be autonomic neuropathy, autonomy in patient, like example for the patient with the diabetic patient. If there is autonomic neuropathy, the patient may have postural hypotension, gastroparesis, there is a bowel changes. So these are the presentation and causes of the peripheral neuropathy. So for the evaluation part of the peripheral neuropathy, so always exclude the diabetes mellitus first. So always do the check for the diabetes, fasting blood sugar level first, and then move on to the other causes. Then you go to the go on to the checking for the vasculitis cause, or if there is any toxin, if there is uremic cause like serum urea, you do the urea level. And if there is any vasculitis cause like the SLE, so you do the anti-nuclear antibody test, right? So firstly diabetes, then others. So this is about the peripheral neuropathy. And this concludes our session on the like the nervous systems. And I want to thank everybody for listening. So until next class, see you in the next class. And this will be our last class on the medicine paper one. And so everyone, best of luck for the exam and prepare well.